ureas as the oldest group related to oral hypoglycemics. We speak about simple classification for oral hypoglycemics into 3 or 4 groups. The first is insulin secretagogues. Insulin secretagogues means drugs which promote the release of insulin from beta cells of pancreas. My example is sulfonylureas. So this is the main mechanism, release of insulin from beta cells. How this occur? If I wanted to clarify the mechanism of action, I can say that this sulfonylurea act by blocking potassium channels on these beta cells plasma membrane. I can say that sulfonylurea block ATP sensitive potassium channels on the beta cells plasma membrane. If this occur, it will allow the release of stored insulin in response to glucose. Once I have much glucose in the circulation, the excessive amount of insulin will be easily released from their stores through using these secretagogues or sulfonamides. It can be known as sulfonylurea. Sulfonylurea have a relation with sulfonamide? Yes. It is sulfonamide derivatives. What is sulfonamide? Sulfonamide is antimicrobial drugs, but the same nucleus, the same chemistry. So if I ask about the discovery of this sulfonylurea, since when? The discovery was related to the use of these sulfonamides as a tools for treatment of typhoid fever by sulfonamide, antibacterial. What occurred? The authors, the physicians, noticed that severe hypoglycemia was found in patients using sulfonamides for treatment of typhoid fever. So, in 1942, the authors, the scientists, start to make their research about these sulfonamides. Why? It's sulfonamide in this dose causes this hypoglycemia for a big number of patients treated from typhoid fever. The research continues and the sulfonylurea as a derivative from sulfonamide started to be used since 1954. So now about 70 years, this is the history of our sulfonylurea, can be considered as the first oral hypoglycemic to be used in treatment of type 2 diabetes mellitus. Again, regarding the side effect, hypoglycemia is the most important. More to occur in elderly, more to occur in impaired hepatic or renal functions. GIT upsets, cholestatic jaundice, allergic skin reaction may occur like any drug. Hematological reactions may occur also like hemolytic anemia or agranulocytosis. What other groups in our recent classification? Number one, insulin secretagogues help the release of insulin like sulfonylurea. Number two, class known as insulin sensitizers. Insulin sensitizers. What I mean of insulin sensitizers? Yes, there are drugs which reduces or can reduce the insulin resistance. Drugs which can decreases or reduces the insulin resistance. Our example for insulin sensitizers are biguanides and the gelitazones or sialidinediones, or simply we can say gelitazones. So regarding insulin sensitizers, I have two important examples. One is biguanides, the second is Gelita, Gelita zone. This is the second class. The third class may be drugs which affect the glucose absorption, inhibit or modify glucose absorption, like a drug known as acarbose. Acarbose is glucosidase or alpha glucosidase inhibitor. So finally, I can make my classification for oral hypoglycemics into three main groups. Number one, insulin secretagogues. My example is sulfonylurea. Number two, insulin sensitizers, which reduces the insulin resistance. My examples include biguanides and glitazones. Number three, drugs which modify or affect or inhibit or decrease glucose absorption. They are known as acarbose, which can be known as alpha glucosidase inhibitor, or its mechanism of action, alpha glucosidase enzyme inhibitor. Regarding biguanide, how many examples I know? Biguanides were only two examples, metformin and fenformin. Metformin glucophage, well known all over the world, and fenformin. Nowadays, only metformin. What about fenformin? Fenformin has a bad side effect of lactic acidosis. Lactic acidosis, which occur in limited cases in case of metformin, but in fenformin, this lactic acidosis was so much. So since maybe 1990 or 1992 or 3, the fenformin withdrawn from the market, obsolete, not to be used. So regarding biguanides, which is insulin sensitizers, I have only one example, which is metformin. For the main indication, like oral hypoglycemic sulfonylurea, type 2 diabetes. This is the main indication. Treatment of type 2 diabetes. Also, cases of obesity may get benefit from biguanides. What about mechanism of action? I have different mechanisms of action, like reduction of hepatic gluconeogenesis. So the synthesis, the formation of glucose will be minimized, will be decreased. Also, decrease the glucose absorption. So my drug will be like euglycemic, help to maintain the normal blood level of glucose. Increase the glucose uptake in skeletal muscles. So no much glucose will be spreading in the circulation and causing hyperglycemia. Reduction of plasma glucagon. We know that glucagon have opposite effect to insulin. So when I reduce glucagon, I get much better chance for the action of insulin. Finally, increase the insulin binding to insulin receptors. So I have many mechanisms related to biguanides. Biguanides not like sulfonylurea, hypoglycemic, but this drug try to maintain the normal blood glucose level, try to make this patient euglycemic like this by different mechanisms like reduction of gluconeogenesis by the liver, decrease the glucose absorption, increase the glucose uptake by skeletal muscle, reduction of glucagon, and increasing the insulin binding to insulin receptors. These are different possible mechanisms of action for this metformin, which is biguanide, which is insulin sensitizer. Possible adverse reaction may occur, mostly gastrointestinal upsets, maybe colic, maybe diarrhea, maybe nausea, like this. A limited number of lactic acidosis, not so much, like fenformin, which obsolete nowadays due to this bad side effect. Long-term use of this metformin may interfere the absorption of vitamin B12, and my patient must receive this vitamin B12 as a replacement. So these are the possible adverse reactions for metformin or biguanide. Still, we have another example as insulin sensitizer, which is glitazone. This thiazolidine diones, or simply you can say glitazones. You can say glitazones. I have two examples: true glitazone and rosiglitazone. Troglitazone and rosiglitazone. What about these drugs? They increase the tissue sensitivity to insulin. They increase the tissue sensitivity to insulin and decreases the resistance for insulin. Which is better, troglitazone or rosiglitazone? Unfortunately, this troglitazone is hepatotoxic, not favorable. But rosiglitazone is less toxic. So for me, I prefer rosiglitazone. Also, I prefer rosy color, not to forget. Rosiglitazone better than troglitazone. Why? It is less hepatotoxic than troglitazone. Finally, the last group or last class of our oral hypoglycemics may be drugs which modify or inhibit the blood glucose absorption. My example is acarbose. Acarbose. What is the role of carbose? This acarbose inhibit brush border alpha glucosidase enzyme. What is the role of this enzyme brush border alpha glucosidase? It helps it promote the glucose absorption and allow more and more glucose in circulation and hypoglycemia occurs. So my drug, acarbose, inhibit this enzyme. If I inhibit this enzyme, which can occur, slowing the absorption of carbohydrate, the absorption will be minimized and hyperglycemia can be controlled. So I can classify this alpha glucosidase inhibitor or acarbose as the third class for oral hypoglycemics. Now we have finished the second line of treatment in cases of diabetes mellitus underlined by oral hypoglycemics. Many thanks for all of you. Any question, Muhammad? Any question, Dini? Any question, Nabila? Mommy? Anyone? All is clear nowadays? This day is clear?
Yes.
Yes. Alhamdulillah. Okay, Muhammad?
Okay, inshallah.
Inshallah. Next time, we will speak about insulin, preparations, precautions, administration, side effects, all mechanism of action, all what's related to insulin will be, inshallah,